Hi, everyone. My name is Janik Goriev, and I'm the Senior Health Information Specialist. Actually, I'm not the Senior Health Information Specialist anymore. I'm the Senior Health Education Engagement Specialist with Brain Tumour Foundation of Canada. I've got a new role, actually. With everything happening in our communities across the country and across the world, we're really grateful for you to be online with us today. And we're really grateful for technology like this as we're all self-isolating and moving forward with life. So just on that note, in alignment with the rest of the world and in order to help mitigate the spread of COVID-19, we just wanted to let you know that all staff at Brain Tumour Foundation of Canada are working from home until the end of March at this point, and then we will reassess. Our office does remain open for receiving mail and packages, but we do ask that all other inquiries be made through phone or by email. It may take us a little longer to get back to you, but know that we are still here and appreciate your patience as we all move forward with what's happening in the world. We will also be postponing all in-person events between now and April 30th. This is a temporary measure, of course, aimed at reducing the risk of transmission to our most vulnerable population, our staff and our volunteers. And so what we would like to suggest is for any updates from Brain Tumour Foundation of Canada, please visit braintumor.ca, and you'll see at the top of the landing page a message about COVID. So when you click there, we'll be keeping all updates happening there regarding Brain Tumour Foundation of Canada and programming and events moving forward. Okay, so now back to our regular programming, so to speak. Our mission is to reach every Canadian affected by a brain tumor through information, education, support, and research. And one of our main goals is to provide current information on brain tumors for our community. So this webinar series is just but really one educational program that we offer to those affected by a brain tumor. So please make sure you check out our website, which is our newly launched website back in January. And you can see all past recordings of our webinars from last year and this year as well. And so before I introduce Kelsey, just a few logistical things. Everyone has been muted automatically, so we don't have background noise. If you are having difficulty hearing me or hearing Kelsey, just make sure your volume is up. If you have a question or any comments or concerns, please just type it in the chat section. That comes to me directly. And what we will do is at the end of Kelsey's presentation, we will take up your questions then. If by some chance we don't get to all the questions, if we run out of time, we will follow up with you this week regarding your questions and get some answers to you from Kelsey. But before we get started, we just want to get an idea as to who is online with us today. So if you could just choose one that best describes you today. Are you a patient, a caregiver, a family member or friend, healthcare professional, or do you currently volunteer for Brain Tumour Foundation of Canada? So I'll give you a moment to answer that question for us. Okay. Looks like people are still voting, so just give me 1 second. All right, here we go. So just to give you a heads up, Kelsey, 31% of the people online with us today are patients or survivors, 12% are family members or friends, 46% are healthcare professionals, and 12% are volunteers for Brain Tumour Foundation of Canada. And just one more question to the audience. How did you hear about today's webinar? Was it through Brain Tumour Foundation of Canada communication, through social media, a family member or friend? Do you just happen to come across it online, or were you referred by a healthcare professional? And it does not surprise me that the majority of you heard it from our Brain Tumour Foundation of Canada communications, because our marketing team is awesome. So virtual high fives to them. They're very good at promoting our events. So 72% heard about this webinar through our communications, through our marketing team. So thank you for taking a moment to answer those questions. And so without further ado, I will introduce our presenter today, who is Kelsey Goforth, has been with Dying with Dignity Canada for 5 years. She currently holds the position of support program manager. Before Bill C-14, Canada's assisted dying legislation, came into effect, she helped to facilitate the first national physician-led training webinar on assisted dying. Kelsey is responsible for helping Canadians to navigate their end-of-life options and the often complex process of accessing medical assistance in dying. She has supported hundreds of patients as they consider their end-of-life options and is a fierce advocate for those whose rights are infringed upon. She works closely with physicians, patients, and their families to help them navigate the healthcare system and ensure that they have the information needed to make the end-of-life decisions that fit with their personal values and medical priorities. Medical assistance in dying, also known as MAiD, was made legal in 2016. However, suffering Canadians continue to encounter widespread barriers to accessing their right to a peaceful death. During this presentation, Kelsey is going to explore what this means for the future of healthcare and patients' rights in Canada, as well as the unique challenges that Canadians face when navigating their legal end-of-life options. So Kelsey, thank you so much. I'm sitting in my home in London, Ontario. You're sitting in your home in Toronto, Ontario, to help us with this presentation today. So I pass it off to you to educate us on this very important topic.
Thank you. Thank you so much for having me join this afternoon. Happy to be here. So we will get started with an overview of Dying with Dignity Canada and what this organization does. So we're a national human rights charity committed to improving quality of dying, protecting end-of-life rights, and helping Canadians avoid unwanted suffering. We've been around for 40 years now. It's our 40th year this year. And of course, we haven't had assisted dying as an option in Canada that whole time, but beforehand, we were advocating for people to have that choice. So in addition to what is listed on your screen there, advocating for assisted dying rules that respect the Canadian Constitution, providing support to individuals and their families, working with clinicians. Another big part of our role is intervening in court challenges to the federal assisted dying legislation to make sure that it is respecting the Constitution and individuals' charter rights. And we'll get into some of that shortly. Before we get too far, though, I'd like to just go over a quick terminology note. And there's often misunderstandings or a bunch of different terms floating around. So I just wanted to clarify a bit of that. So in Canada, what we commonly refer to as assisted dying or medical assistance in dying, which is shortened to MAiD, MAiD, actually encompasses two different options that people have. So the one is voluntary euthanasia and the other is assisted suicide. So you can see there on your screen that one involves a healthcare professional actually administering medication through an IV, and the other is an individual taking medication orally to end their life that way. So both of these are currently legal in Canada. We don't call it physician-assisted dying because nurse practitioners are also allowed to provide this medical option. And if we said physician-assisted dying, then we'd be leaving them out of that terminology. So those are the two options. And moving forward, I'll be referring to this as MAiD or assisted dying. So I was asked when we were planning this webinar to include a bit of a note on the difference between suicide and medical assistance in dying. So I found this infographic. It's not Dying with Dignities. It's actually from the Center for Suicide Prevention, but it did include some helpful comparisons or points. So the one or the couple that I'd like to point out are the difference between being alone, which is often the case for individuals who choose suicide, versus being with a medical professional and having family involvement in that decision if a person wants. There's no requirement to have your family involved if you don't want to. Just that difference between doing something in isolation versus as part of a medical decision. And the difference too, it says on the third point there, between suicides often being very violent versus medical assistance in dying being a violent medical intervention. So this is available online if anyone wanted to access it, but I thought it was a pretty good infographic to just explain some of those differences. So what we'll do to get started is just have a bit of a discussion about how we got here. So the two ladies that you see on your screen there are Gloria. She's on the right, seated in the purple shirt there. And Gloria Taylor had ALS, Kate Carter had spinal stenosis, and it was the court case that these ladies brought forward and their families that ended up giving us the right to an assisted death here in Canada. I think my screen sharing may have stopped for a second. Sorry about that, folks.
I can see it on my end, Kelsey.
We're still up? Okay, perfect.
Yep.
I just had it beeping at me for a second. Glad we're good. So these two ladies, neither of them lived to actually see the Carter decision, as it became known, come down, unfortunately. So Gloria Taylor died of an infection in the fall of 2012, and Kate Carter accessed an assisted death in 2010 in Switzerland. So Switzerland is the only country that allows non-residents to access that option, and that's the option that she chose back in 2010. So the Carter decision, February 6th was a very big day. I had just started working at Dying with Dignity a couple weeks before then, so it was a very exciting day for us in our office. This was the day that the Supreme Court of Canada ruled unanimously that the prohibition on assisted dying infringes on individuals' Section 7 right to life, liberty, and security of the person. After this decision was released, the government was given 1 year to draft their legislation. But as that 1 year mark was getting closer, the government asked for an extension. They said they weren't quite ready and wanted to take a bit more time to sort out what the legislation would look like. They were then given a 4-month extension that brought us to June 2016. And since then, we've had more than 8,000 Canadians access an assisted death. It should also be noted, too, that in December 2015, prior to the Supreme Court's decision being released, Quebec moved forward with their own legislation called Bill 52. So that means that we actually have 2 separate assisted dying laws here in Canada, one for Quebec and one for the rest of the country. So we'll take a quick look at what is medical assistance in dying, and we're taking this directly from the assisted dying legislation. So like I said earlier, the administering by a medical practitioner or nurse practitioner of a substance to a person. So this is, like I said earlier, the IV option, or the second option there, which is the prescribing or providing by a medical practitioner of a substance that the person would self-administer. So essentially drinking a liquid, and this is referred to as the oral option for medical assistance in dying. Okay, and who is eligible? And again, these pieces here are taken from the federal assisted dying legislation. So individuals need to be eligible for publicly funded health services in Canada. This was likely included, and we're just guessing, we weren't there for this this decision being made, but it's likely that they included this in the legislation to avoid a system like there is in Switzerland, where people can come from outside of the country solely to access an assisted death. So that's probably why that piece was added in. Individuals need to be at least 18 years of age and have the capacity to make their own medical decisions. They need to have a grievous and irremediable medical condition, and that includes all of the points listed below there. So a serious and incurable illness, disease, or disability. You have to be in an advanced state of irreversible decline in capability. The illness, disease, or disability has to be causing suffering that's intolerable to the person and can't be relieved by any treatments that they consider acceptable. And their natural death needs to be reasonably foreseeable. It should be noted, too, that there's no requirement that a person has to undertake treatments that are not acceptable to them. And a note on the suffering requirement: suffering can be very individual, and suffering might look different from person to person. So that really depends on what that individual is going through and what intolerable suffering looks like to them, because it is such an individual experience that people go through. They must also make the request voluntarily, so no signs that the person is being coerced or pressured. And they also have to be aware of all their medical options so that they have informed consent when making that choice. So reasonably foreseeable natural death is one of the requirements that I mentioned. And we have this question mark here because it's quite a difficult term to interpret in a lot of ways. Eligibility is not limited to those who are terminally ill or at the end of their life, but they do need to have a reasonably foreseeable natural death. It's been very difficult for clinicians to interpret this very ambiguous legal term in the medical community. So taking a term like this and applying it to individuals has proven to be a bit challenging. Some clinicians have told patients that they don't qualify because they feel their natural death is maybe more than 6 months or a year away. And we were especially seeing that in the early days of having MAiD as a legal option. There was a court challenge, though, in Ontario in the spring of 2017 that helped to provide some much needed clarity to this term. So the woman who brought this case forward was 77 years old. She had severe osteoarthritis, and she went to court to try to get that clarity that she needed. So the judge in this case came back and said that, you know, he's not a doctor, he's not a nurse practitioner. It's up to the clinicians to make the decision. But in his legal opinion, he felt that she did meet the reasonably foreseeable requirement because she was on the trajectory towards death. He also clarified and reiterated that the person doesn't need to be imminently dying, but that they do need to be on that trajectory towards death. And he also said that clinicians who are doing these assessments need not opine over the specific length of time that a person does have remaining in his or her lifetime. So with this decision in mind from this judge in Toronto, this lady, she was called AB in the courts, her identity was protected. She was able to move forward with her request for an assisted death. And even though this case was here in Toronto and it was related to one specific individual, it was used and still is used by clinicians all across the country. So when they're looking at individual cases, they'll often refer to this one because it gives them such clarity on what reasonably foreseeable natural death might mean for their patients as well. So some of the safeguards that are in place, and all of this is found in C14, the Federal Assisted Dying Law. Each person making a request has to put their request in writing, and this request also has to be witnessed by 2 independent witnesses. If individuals can't physically sign their name and put the date on the form, they can have a proxy do that on their behalf. So the issue with witnessing and what's made it quite difficult is that there are requirements that the independent witnesses must meet. They need to be the age of 18 or older, but then it gets a little bit more complicated. So the individuals who can be witnesses cannot be a beneficiary under the person's will, or they can't be anybody who's going to be receiving any financial or material benefit. They can't be the owner or operator of any healthcare facility that the person is in. They can't be involved in providing healthcare or personal care to the individual. So we see this as a major barrier for people, because when we think of individuals who are at the end of their life and who are suffering and often, you know, not even able to leave their homes, it gets quite difficult to find people who could even act as witnesses, given the criteria that is in the law. And we just see it as a major privacy concern for individuals as well who are making this decision, but needing to loop in people who are outside of their circle of care or outside of their immediate family, and essentially having them be privy to that information as well. What we did to try to support people who were struggling to find witnesses is we launched an independent witness program. This was in late 2016, and we've helped hundreds of patients since then. In 2019, our witnessing volunteers witnessed for over 1,000 patients. So it's a very often used program for people all across the country who are struggling to meet this requirement in the law. So procedural safeguards. Like I said, the witnessing request is one. Individuals also need to have 2 doctors or nurse practitioners assess them and determine if they qualify under the current law. There's also a waiting period. It's 10 clear days from the time that a person puts in that written request, and that's the first date that they would be able to move forward. There's no requirement to move forward after those 10 days are up. People might wait much longer, but there is that 10 clear day minimum currently. There are exceptions to this as well. So if the 2 assessors, doctors or nurse practitioners, both agree that the person might lose capacity or die naturally before the 10 days are up, then those 10 days could be waived entirely or shortened. So that is an option for people as well in some cases. And the other safeguard there is the opportunity to withdraw your request at any time, including immediately before the procedure is set to take place. So there have been a number of court challenges to the law, and I mentioned this early on that there are concerns that the law is not constitutionally sound and is in violation of some individuals' charter rights. So there's 2 that I've listed there. One that we often refer to as the Quebec case, and Truchon and Gladue are the 2 plaintiffs in that case, and the other one is the Lamb case. And that refers to Julia Lamb, the plaintiff in that case. Just in the interest of time, and because the Truchon and Gladue Quebec case ties in more directly to what we're experiencing currently as 2020 moves forward, we'll be focusing on that Truchon and Gladue case. But if there are questions about Lamb, I'm happy to answer those during the Q&A or through email or whatever, phone call even if you're interested in learning more. So, whoops, sorry. So this case here, the Quebec case, this was Truchon and Gladue, both are individuals living with degenerative diseases, and they were both told that they don't qualify under the current law. They're based out of Quebec, so their court challenge that was moving forward was challenging the Quebec law that was operating in their province, but also the federal assisted dying law as well. A decision was released in that case in fall of 2019 in favor of the plaintiffs and said that the judge in that case agreed, felt that the law was unconstitutional and that it needed to be changed. The government was then given 6 months to prepare for this change, which brought us to around this time, mid-March 2020. But the government did ask for an extension, which was granted. So we do expect legislation to come into effect in mid-July 2020. And we'll talk a little bit more at the end about what that proposed legislation looks like. But I just wanted to give a bit of background on that court case and sort of how we got to this place where we're at now. So we talked a bit about the safeguards in place and how some of them, mainly the witnessing component, can be a bit stressful and lead to delays and lead to some added, I guess, tension for people who are trying to move forward. But I also wanted to talk about some access issues that we're seeing when it comes to both institutions and individuals. So one major barrier is when it comes to public taxpayer-funded institutions, mainly hospitals. At this point in time, there are hospitals that are opting out of allowing assisted dying to take place on site. Our view as an organization is that if it is a public institution that's receiving public funds, that they should be allowing public healthcare on site, including medical assistance in dying. And how this has impacted people is that sometimes in certain regions there is only one hospital, and if that hospital is opting out, then people might have to leave their communities in order to access MAiD in an institutional setting. So that can lead to delays, and that can lead to patient transfers of people who are often so ill that they shouldn't be moved at all for any reason. except in an emergency, but these people are unfortunately being forced to move out of their local hospitals and communities to be able to move forward in some cases. And for some individuals, they physically cannot be moved, and they may, as a result, be denied access to MAiD at all. So the second access issue that I wanted to discuss here is physicians who object to providing assisted dying. And as an organization, we feel that not every doctor needs to be or should be involved with medical assistance in dying if they don't want to be involved. So doctors definitely have that right to opt out if it's not something that they want to do. But we do feel that at minimum there should be an effective and timely referral in place. I think there should be, we think as an organization, that there should be that balance between protecting physicians and making sure that they feel comfortable, but not abandoning patients who are trying to move forward with the health care that they're looking for. Dying with Dignity Canada was an intervener in a court decision here in Ontario to uphold a regulation from the College of Physicians and Surgeons of Ontario. They have a policy in place on effective referrals, and it applies to medical assistance in dying, but it also applies to other types of healthcare, abortion, prescribing birth control, that kind of thing. And there was a group of Christian dentists and doctors that were trying to challenge that policy that's in place and essentially wanted to have that changed or removed because they felt that clinicians might be forced to be involved in something that they didn't want to be involved in. So this went to court, this challenge here, and in that decision, the Ontario Superior Court judges, there were 3 of them on a panel, and they ruled in favor of the defense, the CPSO, arguing that the policy is constitutional and functions to protect patients who request MAiD, but also protecting doctors from not having to be too involved, but also not abandoning anyone. There was an appeal to this decision in January 2019, and the decision again was upheld, so that still stands. So there are some groups of individuals who are left behind by what we have currently. When the legislation was first drafted, it was determined that further study would be needed to look into possibly expanding the legislation to include the groups that you see on your screen there. So mature minors, people under the age of 18, people with mental illness as the sole underlying condition. And this is not to say that people with a mental illness diagnosis can't move forward with MAiD now. If they meet all the other criteria in the law and they have a mental illness diagnosis as well, they should be able to move forward so long as all the other criteria is met. But if somebody doesn't meet all the criteria, then of course they couldn't move forward. And advance requests. So this is when this would happen when a competent person makes a request for assisted dying that could be honored at a later date once they've lost the capacity to make medical decisions for themselves. So that's not currently permitted in Canada. It is permitted in some other jurisdictions, including the Netherlands and Belgium, but it's unfortunately not an option right now. So what we've been seeing since advanced requests are currently banned is that some people have chosen to access an assisted death earlier than they otherwise would have because of their fear of losing capacity. One of the examples of this is Audrey Parker. She was in the media quite a bit in recent years before she died, speaking about how she wanted to live to see one more Christmas, but she opted to die in early November instead because of that fear of losing capacity. So those 3 groups, as mentioned, were sort of put aside for now is how the government was looking at it. They wanted to get the legislation passed, and they wanted to loop back and then try to explore this, the possible expansion a little bit more later on. A clause in Bill C-14, the assisted dying law, did require that the federal government commission independent reviews into those 3 groups. So 6 months after the legislation passed, they did assign the Council of Canadian Academies to study these three groups that I mentioned. And there was a report that was released at the end of 2018 that provided a lot of information, a lot of consultation with various experts. It was almost 800 pages long, but there was nothing that was implemented into law at that point in time. Which brings us to what is next. So as part of the federal assisted dying law, they also required that there be a 5-year review. So we're entering the 5th year of Bill C-14 being in place, and that 5-year review will be starting in the summertime. And as part of that 5-year review, they will be looking at the 3 groups that were that I just mentioned, as well as other areas of the assisted dying law that might need to be reflected on and changed as we've seen this play out and as things have moved along in the last number of years of having legislation available in Canada. And then there's Bill C-7. So as mentioned with the Quebec case, Truchon and Gladue, the government needs to make a change to the federal assisted dying law and the Quebec law because it was deemed unconstitutional, mainly that reasonably foreseeable natural death component of the law. So there has been something drafted. It's not finalized yet, but there is a piece of legislation that is available. It's online if anyone wants to read it fully, but it's out there and ready to be debated and looked into a little bit more. So some of the changes that are being proposed is having 1 witness instead of 2 witnesses. So that removes one of the witnesses that a person might need and will hopefully cut back on some of the difficulty that people are having with finding witnesses. They also say that the witness can be a paid personal or healthcare worker, so that provides a bit more clarity as well and will hopefully cut down on the struggles that people are facing. They're removing the 10-day reflection period. This is for most people, and we'll get to the nuanced part in a second, but for many individuals, that 10-day reflection period will be removed. And they're also saying that the final consent piece, so the final I guess, confirmation that an individual would give their doctor or nurse practitioner might not be needed if there's something agreed upon beforehand and documented that says, you know, if I lose capacity and I'm supposed to have an assisted death on March 30th, you can still move ahead. So that piece is in there as well. Where things get a little bit more complicated is that there are 2 streams that people would find themselves on. So one is if the person's death is considered reasonably foreseeable. If that's the case, then the reflection period is waived. But if their natural death is not considered reasonably foreseeable, they actually have a much longer wait period than anybody would have at this point in time. So if somebody's natural death is not reasonably foreseeable, then there would be a 90-day wait. And this can be waived if there's risk of capacity loss. But for many people, if they're applying because of chronic pain issues or, you know, a condition like that might not necessarily be causing their death anytime soon, they'd have to wait much longer. And the individuals who fall into that not having a reasonably foreseeable natural death group would also have to have one of the assessors be somebody with a special expertise in their condition, which currently is not the case. Currently, the nurse practitioners or doctors who are assessing don't necessarily have to be specialists in whatever the condition is. They often do consult with specialists who are treating that individual, but they don't have to have any expertise in that condition. So as mentioned, this is not passed yet, Bill C-7, and it will be debated and hopefully lots of space for organizations like ours to be involved in some of those discussions. And this is quite new. This just came out a couple weeks ago. So we're speaking with clinicians, trying to get an understanding of how everything might play out if it passes as is. But you know, it's positive in a lot of ways, since reasonably foreseeable natural death will be opened up, and people don't necessarily have to fall into that current definition, but there are some other safeguards that might cause issues for people. So one question that a lot of people will have when it comes to, you know, hearing all of this information, the legal piece, the medical piece, is about access and sort of where to start if this is something that someone is interested in. What we've seen is a lot of the provinces stepping up and coming up with centralized referral systems. So people can call or email whatever agency is available in their province, and get a referral that way. Sometimes you can even do that without a family doctor being involved. It's sort of a self-referral thing for a patient or family member or caregiver to make that call. There is the option of speaking to one's own family doctor or nurse practitioner. As mentioned, there is a requirement here in Ontario, at least, for those opting out to still provide an effective referral, but in practice, sometimes that doesn't happen. We still get experiences shared with us from people reaching out saying, you know, I tried to talk to my family doctor and the conversation just kind of got shut down. So there are those regional or provincial referral systems that are set up to help people through the process, provide information, and try to get people connected with who they need to be connected with. Dying with Dignity Canada also has a page on our website that has a number of resources to help with navigating assisted dying, and we're available to talk on the phone or through email if people wanted to talk through any of the steps or wanted any clarity. So I think I might leave it there and open it up for questions. I know there's a lot of information and a lot going on still with the assisted dying law, so it's a lot to digest. But if there's anything that you wanted me to loop back to and dive into a little bit more, I'm happy to do that.
Awesome. Thank you so much, Kelsey. What an informative presentation. I've had the honor of hearing you present in the past, and I always learn something new every time I hear this presentation with this really important topic. So thank you for bringing us up to speed. We do have a few questions that came through, so let's start with the first one. The first one is, with self-administration of substance at home, what happens if there is not enough medication? Is there a nurse present to monitor?
Yeah, that's a really good question. So there's an organization called CAMAP, that's the Canadian Association of MAiD Assessors and Providers, and they've released a number of clinical practice guidelines. So their focus is really supporting clinicians who are involved, but all the work that they're doing is fantastic, and it really helps with patient access and giving patients and families a better understanding of everything as well. So one of their clinical practice guidelines, it does recommend that if somebody is choosing the oral route, to have a MAiD provider present as well. And the issue is with the oral option is that it takes quite a bit longer than the IV option does. So, you know, the person who's taking the oral option is in a very, very deep coma. So for that person, they're so far asleep at that point. But for the family who's there watching and being with the person, sometimes it can cause some stress if things are going on for quite a long time. So there is that recommendation that somebody is present to help with the process if needed. And I'll also note that there's been very, very few individuals who have chosen the oral option. I think in Ontario, there's only been one, I believe, in like 4 years. And the same with other provinces. It's not really the option that people choose too often.
Great. Thank you, Kelsey. Next question is, what comments can you make about the patient and family experience of MAiD?
Mm-hmm. Yeah, so from what I've heard from the individuals who have gone through the process, it really varies depending on the sorts of barriers that they run into when they're trying to move forward. For the actual death of the person, and I've been present for one MAiD death as well. It's very peaceful. It's very quick. But I think the stress that sometimes affects the experience is, how difficult was it for that person to find a MAiD assessor and provider to come, meet with that person? What was that wait period like? Were there issues with, trying to track down medical documentation? Were there issues with finding witnesses for their form? Were they in an institution that wasn't providing them with the support that they needed? So those things the tension can kind of build up when you're experiencing a lot of those roadblocks. But the deaths themselves, it's overwhelmingly positive what I hear back, and the nice thing is that people often will personalize the experience as best they can. So the person might say, I want this music playing, I want to do this the morning of, I want to, I want a poem read, I want to eat this last meal, I want to do a champagne toast. There's different ways that people will bring their legacy to that moment. A lot of people will do something beforehand with others, like a sort of a living wake in the days before, where they're able to say goodbye and celebrate their life in a way that is special to them and special to the experience that they're going through.
Very comforting. Thank you. So next question is, do you think that this government has any real intentions to redraft the legislation, or do you think it'll be delayed and delayed and delayed? I mean, before you answer that, I will say that since this topic became more public and more people kind of, weighing in on it, I have to say that it feels like the government and the governing officials have done a pretty good job at keeping us up to date regarding the legislation and getting feedback from people who have used the service. So I don't know if you can comment on this question at all, Kelsey.
Yeah, I mean, I think that even before the Truchon Gladue decision in Quebec, even before that decision was released, there were conversations happening. There were statements where different politicians acknowledged that the law wasn't quite where it needed to be. So I think that the intention is there. I think the concern right now is making sure that things can move ahead, that the eligibility requirements can open up to where they need to be without too many additional barriers to access for those individuals. So, and in terms of timeline, I mean, they asked for the extension and they got the extension. I don't know if they're able to ask for another one, or if this is sort of the last opportunity for them to come up with legislation. And then we, of course, have the COVID-19 situation on top of everything else. So I think the intention is there to open things up, but hopefully there isn't too much in the way of individuals. Like it's all about striking that balance and making sure that people are protected and making sure that there are appropriate safeguards. But some safeguards also have side effects that I don't think were anticipated when the law was first being drafted, such as the witnessing requirement, because really people are going in and as a witness, what you do is you confirm the person's identity. So if you're witnessing for your neighbor or somebody that you know that person. But if you're witnessing for somebody that you've never met before, which is what our volunteer teams are doing, then they have to confirm the person's identity. So they go in, they check the person's ID, or they check their hospital bracelet if they're in an institution, and then they watch them sign and date the form. So there's really, there's no, that's the extent of the witnessing experience. It's the clinicians who are asking about, is this what you really want? Have you considered this? Let's talk through things and see just how you're feeling. So they're really ticking off a lot of the major safeguards, and the witnessing is just sort of a logistical nightmare for a lot of people because they're trying to find witnesses. They don't know who to ask, and it's adding a lot of stress for something that's not really adding much protection. So I think that's the concern at this point, that whatever comes into effect with the opening up of the eligibility is not harming people in the long term because of safeguards.
Mm-hmm.
They're too much. Yeah.
Sure thing. Thanks, Kelsey. Another question is, if everyone had timely access to palliative care if needed, do you think that there would be as many requests for MAiD? Has there been any conversations around, having more access to palliative care hospices and versus, using MAiD as a service?
Yeah, definitely. So as an organization, our feeling is that palliative care is needed and is important, and everybody who needs palliative care should have access to it. We also see it not as an either or situation. So a lot of people who do end up accessing MAiD are also receiving palliative care. And in a lot of other jurisdictions where assisted dying has been happening for a lot longer, like Oregon in the US and different European jurisdictions, they found that I think Oregon is where this stat comes from, but 9 out of 10 people who chose assisted dying were receiving palliative care. And in various European jurisdictions, there was also a increase in sort of the attention paid to palliative care as assisted dying became an option. So they were seeing this as end-of-life options in general, both of them, palliative care and assisted dying, both need those resources and that discussion, and for people to be aware that those are options. I mean, there's definitely not enough palliative care available for people across the country, and that's something that, as an organization, I think we want to have those discussions and keep the dialogue going about that. But when it comes to the suffering and what I hear from a lot of individuals who move forward, they'll say, my physical pain is under control and I have, nursing support, or I have, medications and this and that, but it's the suffering that I'm feeling emotionally or mentally, knowing what's coming and knowing that I'm, I might be unable to do the things that I could do before, and I'm, I just want to have that autonomy over what's going to happen. So a lot of the time it is the suffering piece is more so related to that mental or emotional suffering that people are going through, because their pain, might be under control physically, but they're still experiencing some suffering in other ways.
Well, that segues perfectly into my next question by our social work student. Can you speak of some of the changes that are in process for MAiD legislation specifically around health, mental health?
Yeah, so there is that Council of Canadian Academies document that I mentioned earlier on, that report that they've come up with, that has some good recommendations. What happened with the Bill C7, so the proposed assisted dying law that is floating around, not approved yet, but might be. They specifically say in that this bill won't be addressing people with mental illness as the sole underlying condition. So even if somebody's natural death is not reasonably foreseeable, with the proposed bill, that would be opening up. But they're saying that would not apply to people with mental illness as the sole underlying condition. So that leaves us then with this 5-year review where mature minors, as well as the mental illness component, can be, I guess, examined a bit more and debated a bit more, and a bit more dialogue about that. So what we're waiting on as an organization, we're coming up with our next steps and are getting ready for the 5-year review that's coming up. But we're hoping that there is space for individuals across the country to be involved with that and to share their thoughts on what they think should happen. But yeah, with C7 that's proposed, they're not looking into that right now. So it will be that 5-year review where we have the opportunity to talk about the mental illness folks.
Great, thank you. Just 2 more questions, and then we'll wrap up. So if any other questions come in after the second question, we will follow up with everybody via email. So the other question is, with the proposed changes to Bill C-14, what illnesses or diseases would qualify as reasonably foreseeable and not reasonably foreseeable? I'm not sure if you can answer that one yet, Kelsey.
Yeah, so I don't think I can, just because everything, even currently, without the new legislation that's proposed, eligibility is so specific to the individual. So they're not just looking at one diagnosis, and when I say they, I'm meaning assessors and providers. They're not looking at one diagnosis. They're looking at the whole, the condition of the individual in general. They're looking at everything that's going on mentally, medically, and also their, what's happened over the last number of years with their health, how things may have been changing. So it's hard to say, with this condition, yes, this condition, no. And with the current legislation as it stands now, even clinicians don't always agree on who qualifies and who doesn't. And there's been, very experienced assisted dying clinicians, and some might say no, and the other one might say yes, just because the reasonably foreseeable natural death piece, it is, trying to interpret that has been a bit challenging, and what we see is a lot of individuals who have very complicated medical conditions or medical histories, and it really does come down to that individual clinician looking at absolutely everything that's happened over the number of years and what they're experiencing today. So it's hard to say.
Sure thing. Thanks, Kelsey. And last question we'll take for today is from one of our social workers, Denis. Could you speak more to accessing the volunteers that witness? Is it a straightforward process? Is it a timely process? Any comments about that process in general?
Yeah, definitely. So I will say right now with COVID-19, our witnessing program is unfortunately on hold. It was a very difficult decision to make, but we have to, with social distancing and trying to protect our volunteers, many of which are older and some have underlying health conditions. We want to protect them. We want to protect the public and try to keep people isolated from each other as best we can physically. So that's on hold right now, but we'll pretend that if it were a normal time and we weren't going through the COVID situation, it depends on where individuals are. So in some cities, London, Toronto, Vancouver, Ottawa, Calgary, Edmonton, mainly. Those are the big cities where we have quite a few witnesses who are often available quite quickly. Getting people in to see a person and get those witnesses, it's usually pretty quick. Often we can get people in the next day. Sometimes we've been able to get people in the same day. It does depend on volunteer availability though. So how it works is if we get a request for 2 witnesses in London, we'll email our London team and say, who's available. They need to move forward as soon as possible, and then just wait and see what we hear back. So it's our volunteers understand that it is such a stressful time for individuals, and that we try to get in as quickly as we can, and especially because there's the 10-day wait that a lot of people have to go through. So we want to make sure that we can get the form done, so then that's out of the way, and the person can get started with the 10-day wait. Unfortunately, a lot of people do are at risk of capacity loss and that kind of thing. So we want to, and the 10-day wait can be waived, but that form does need to be filled out. So if the form isn't filled out, then the clinician can't move forward. So yeah, we try to get people in as soon as we possibly can.
Great. Thank you, Kelsey. Thank you so much for taking the time to be with us today and for sharing your knowledge and your expertise with us on this very important topic. So virtual high five to you and virtual high five to everybody who joined us online today. Before I sign off, though, I'm just going to, Kelsey, I'm going to switch the presenter mode to me for a second so everybody can
Sure.
see my screen. Just while I have everybody on the line, a gentle reminder that this is our landing page on our website. And at the top here, you'll see this is where you can click to get more information on any updates from Brain Tumour Foundation of Canada regarding COVID-19. This up top here, Brain Tumour Walks, as we mentioned earlier, you know, we're just monitoring things right now. Right now, we're a go for the walks, but you know, we don't know what's happening in the next few weeks, so we'll just kind of monitor that. But if you do want to register, you can still register, you can still donate, and so on. And then also on our website here, if you go to the helpful information section, it will take you to the webinar series here. So you'll see all the other presentations that are scheduled for this year, including, there's Kelsey. The next one will be on April 29th with Dr. Diaz. He's going to give us an overview of non-malignant brain tumors. And then we have another special webinar happening on May 27th, and that'll be personal stories of hope for brain tumor caregivers and sharing their experiences as well. So don't forget to check out our website for updates, and also keep an eye on our Facebook page. We'll be doing lots of updates there as well and sharing information. So once again, thank you so much, everybody, for joining us today. And thank you, Kelsey. And be well, everybody. Take care.